Translating Research in Elder Care, or otherwise known as TREC, is a research partnership of researchers, knowledge users, policymakers, and citizens, which aims to produce knowledge that improves elder care. This partnership ensures that the research meets the needs of everyone in the residential long-term care sector. TREC's Voices of Individuals, Family and Friend Caregivers Educating Us Advisory Committee is composed of persons living with dementia and family or friend caregivers of residents in long-term care settings who provide input and feedback to TREC researchers, helping to shape the research agenda through new lenses. How has citizen engagement in elder care impacted TREC research? This is episode 20 of Pep Talks, the Patient Engagement Podcast. In this episode, recorded over Zoom in the summer of 2020, we speak with Dr. Andrea Gruneir, a health services researcher in the Department of Family Medicine at the University of Alberta. Andrea shares her experience of working together with citizen partners from TREC Voices Advisory Committee. Paul Ferry first asked Andrea to tell us about the experiences of older adults in the healthcare system and how it differs from care for other adults.
So first, I'll talk a little bit about the group Voices, which is the group that we were originally contacted about. Mm-hmm. I'm part of a research program that's called the Translating Research in Elder Care Program, or they call it TREC for short. And it's led out of the University of Alberta, the Faculty of Nursing. The scientific director is Carol Estabrooks. And the intention of TREC is really around identifying ways to improve the quality of life and the quality of care for people who live in long-term care or nursing home settings, and to improve the quality of the work life for the individuals who work there. Sort of acknowledging that the quality of the work life and the quality of life and care for the residents can't be really disentangled. Voices is a group that was originally brought together to be sort of what we called a citizen advisory board, and we can get into a little bit about why we use the word citizen over patient.
Sure.
To discuss, to help advise TREC a little bit around how they could better orient the research that was going on, both the direction of the research as well as the communication around the research, to meet that kind of citizen perspective. TREC historically has always had a strong relationship with various kinds of decision maker partners. And so building in now a role for these citizen partners was a natural next step. So Voices was sort of formally put in place in 2016. And in that time, we've gone through a few changes in terms of how people want to be engaged, actually. They originally engaged to be a community advisory board or a citizen advisory board, but actually many individuals who are on Voices and many of the investigators actually started, wanted to see more integrated engagement where people would be involved in specific research projects and other specific activities. So the role of Voices changed a little bit over the last several years. Our focus, as I said, is really around the long-term care or the nursing home experience. So the members of Voices represent a few sort of different perspectives there. We have a number of people who are family caregivers to somebody living in long-term care or who was recently living in long-term care. So oftentimes those are spouses or adult children. And then we have a number of people as well who they themselves are not in long-term care, but they are living in the community with a diagnosis of dementia. And I don't know if you're aware of this, but dementia is the number one by far reason why people get admitted to long-term care.
Okay.
So that perspective is really critical for understanding what people perceive of long-term care and what they see as critically important issues. We have tried over the years to bring in someone who lives in long-term care. That's proven to be somewhat difficult, although recently we've been able to identify a couple who will engage in some ways. Yeah. So that's a little bit about the background of Voices. And then you asked about sort of the perspective of people or their experiences in the healthcare system. I think I'll give you two answers for this, maybe.
Sure.
So one is that with respect to people who living with dementia, and I think there are many people who can speak very eloquently to this, there is a lot of ageism and stigma around dementia that is pervasive within the healthcare system, as much of a problem within healthcare as it is just in general society. And so we hear this a lot of people saying they feel that their complaints or their concerns are sometimes written off as being part of the aging process or, you know, related to the dementia, as opposed to really being taken as something that could in some way, in fact, be treated or managed or addressed in a way to better promote sort of quality of life. In particular, for the people living with dementia, we hear a lot about the impact of stigma on how they're treated by other individuals, including those in the healthcare system. The ideas that people with dementia are unable to speak for themselves, that they may have an encounter with a healthcare provider who, as soon as they figure out they have dementia, no longer speak to them directly, are now speaking to their companion, assumptions about what people with dementia can or can't do. And so we know that can really take a toll on people, both in terms of their quality of care that they're receiving, as well as their self-esteem and how they view themselves and their willingness to seek care in other ways.
So you mentioned earlier about the use of the language between sort of the word patient and the word citizen. Do you want to talk a little bit more about that?
Yeah, so this is something that we discuss a lot.
I might have lost you again there.
So even though many places are using that term patient with a very broad umbrella, a lot of the caregivers didn't really feel that it applied to them. The other part of it is that one of our missions is to improve the quality of life and the quality of care provided within long-term care, which to some extent means actually unmedicalizing that setting and sort of acknowledging that's the place where people live, that's where they live their everyday life. And so it's not a place that's just a hospital. And we wanted to identify a term that was going to be less medical, basically.
Yeah.
And many of our participants who themselves live in the community with dementia, they also felt very strongly that they were patients when they were sitting in their doctor's office. But as soon as they left that room, they were not patients anymore. And so the word citizen kind of came from literature around participation of older adults in society, recognition of rights of individuals with dementia or other conditions that might impact on cognitive impairment. So that's where citizen came from. Recently, there's been some discussion. It was someone raised to us actually that they thought citizen was a little bit exclusionary, that the implication was we were talking about people who held a Canadian passport, which was not really where we originally were coming from. But we are certainly open to further discussion about what kind of language is right for our purposes.
Yeah, no, it sort of reminds me of some of the language they use in the UK about patient and public involvement to try and kind of broaden it beyond just the word patient.
Yeah, we were a little bit, I think, probably inspired by that as well.
So part of the role of our team here at the Patient Engagement Platform is to provide advice to researchers who are looking to engage patients as partners in their projects. So do you have any advice or strategies that you'd recommend for engaging patient partners from older populations or other vulnerable populations?
Yeah, we've learned a lot of things over the last several years, and I think to be fully engaged. And so whether that's around addressing things about physical accessibility, hearing or visual impairments, timing, being able to provide childcare or support for people who will be traveling with a companion of some kind, I think you just really have to be aware and maybe even talk to people before you try to play on your first meeting or your first get together to understand what is it that they really need to be able to feel that they can participate. I think it's also really important to be very upfront with your partners that you're looking to work with, and including your research team, what is it that you want these individuals to do in the group?
Mm-hmm.
What is it that you really see as their role, so that you can be very clear in terms of the communication out and in terms of recruiting people and hoping to attract people around what it is that you're hoping you can do. I think we ourselves have run into this situation a few times where the expectations haven't always been laid out as clearly as they should have been.
Mm-hmm.
And that can lead to some difficult conversations down the road, and perhaps making partnership not as successful as it could potentially be.
Do you have any thoughts about the sort of the value that partnering with patients in research brings to projects?
Yeah, I think that one of the things that's interesting is to hear from people what they really see as the critical problems. To see how those opinions align with, or sometimes don't align with, those of people in other roles. In our case, we have a lot of decision makers involved in this work as well. And then, of course, we have researchers from various backgrounds. So it's always interesting to hear from the different groups what they see as really critically important and why. And as much as an epidemiologist, I believe that, an anecdote is not data. I also think there is a lot of value in people's stories. And so the space for having our citizen partners tell their stories, especially as they become more comfortable over the last several years and are willing to open up more and more around various things, I think it's incredibly powerful for people to continue to hear that side of things. Many of us are kind of removed from the front line, so to speak.
Sure.
And so to continue to have that input is really interesting. We've also had a chance to work with our Voices group to write a grant, which was a fun experience.
Okay, yeah.
And it was a SPORE grant that we were actually successful on, and we recently just wrapped up, where we were able to do a priority setting activity, sort of internal to our group. And so that was quite an experience, because it was really a directed way of hearing from the Voices group what they thought were really important research questions, and then having them, without input from researchers, work through the process of saying, okay, what would be the most important ones to tackle in the near future. And so that was very illuminating to hear from them. Yeah.
How did you find that process then of getting patients involved with the grant creation?
So what we did was, there was a call for a SPORE grant for sort of team building, in a sense. And it really fit with what we had been thinking at the time, based on some of the discussions that Voices had been having around where they wanted to see the direction of the group going. And so the way it worked was Stephanie Chamberlain, who's she was a trainee at the time, who's also heavily involved. She and I talked a little bit about what would be some ideas that we could put forward. And we'd heard a little bit from a few of our Voices members who'd participated in other priority setting activities that had been done through the Alzheimer's Society of Canada, that was something they really enjoyed. And we had a reason why we thought it might work for us. So we put it forward to the group, and we said, here's what we're thinking based on these conversations. And then those individuals who had previously participated on a priority setting kind of ran with it. And it was actually their points that I think convinced the other members of the group that this is what we should be doing. We were then able to, we did the whole thing. It took us just about a year, I think, maybe a little bit longer. And we did an evaluation afterwards, and we asked people to tell us what did they think of the process. So that as well was really important, because it let us see where people felt that they truly had been heard, and that they had been heard in a way that they felt like equals with everybody else in the room. They didn't feel that there were any power dynamics that were influencing the conversation. And that was really important to us, to make sure that we were able to carry that through.
Yeah, it's a really interesting point about power dynamics. Do you have any thoughts about how to try and reduce that sort of power dynamics in a group?
Yeah, I think that's something we've maybe struggled with over time, although it's changing as people get to know each other better.
Mm,
One thing we certainly do, and I don't think this is unique, is everybody uses their first name.
sure, yeah.
And we always use our first names. People don't use titles. We are careful to make sure that people know who's going to be at a meeting or in a group ahead of time.
Okay.
So they can be just a little bit aware about what's going to be going on. We try to make sure that Voices members have space on meeting agendas so that there's an opportunity for them to be involved in any of the discussion. One other thing that we've worked at over the years in the larger TREC team is more and more assigned seating
Okay.
at meetings where we have large groups as a way to break up and make sure that we have different perspectives at different tables, things like that. It sounds funny, but it adds a layer of work sometimes to the meeting planning. But I think it's something that's been received pretty well for the most part.
Okay. No, interesting. Yeah.
Yeah. So I think those are some of the main things that we've done.
Mm-hmm. I guess one last question then. Could you talk maybe about some of like the maybe surprise things that you need to build into your scheduling or the research process to make sure that patients are engaged in a meaningful way?
Yeah, there have been a lot of things that we've learned, sometimes the hard way over the years. As I mentioned before, one of the critical things you have to consider is accessibility. And so that became something that we needed to pay more and more attention to over time that we didn't really expect. So, and when I say accessibility, I mean a whole bunch of things. So, we would get feedback sometimes that the menu from a certain meeting, the sandwich bread was too soft and people were having difficulty, people with swallowing problems were having difficulty with it. So then we would start to think about our menus a little bit differently. Okay, what can we be sure will not be an inadvertent choking hazard? We would have to think about the timing of agendas. We didn't want to start too early in the morning because for people with dementia or for people who are coming from long-term care, it's not feasible to show up at an 8 a.m. meeting necessarily and expect people to be ready to go. So pushing things back where we could, being aware of how long we were keeping people at meetings, the timing of those meetings. Teleconferences, for example, have worked with mixed success, but when we switched to using a platform like Zoom, people really like to see each other. Okay, and I think that really improved their comfort in not just talking into the void, that they could see others' faces. There's also an issue of budget, which we've sort of pushed more and more in the last few years. It's making sure that people are budgeting to pay for their citizen partners' time. Okay. Since it's, and I know this is in line with some of the recommendations coming out of SPORE, we really want to make sure that we acknowledge people's contributions, but at the same time, being aware that we don't want to just, sometimes people don't want us to pay them because of other benefits that they don't want it to interfere with. So ensuring that we have other ways that we can provide them with some kind of honorarium or some kind of token of appreciation for the fact that they're often volunteering their time, sometimes lots of it. So just trying to be, to acknowledge that.
Yeah. Have you any tips for people? Well, one of the main questions we get as a team, I guess, is how do you even do that if it's not just a traditional honorarium? Any
We have really struggled with that, and some of it is that the university processes that are in place. We had one situation where we offered people, if they wanted instead, we could make a donation on their behalf. It was a lot of work though, and I have to admit my finance person in the department was not very impressed with the whole thing. We were able to get it done, but it was a lot of extra work. And I think one of the other, we have not actually done this yet, nobody's asked for it, but I've also seen people ask to have like a course or something like that
Mm-hmm.
paid in lieu of getting the money directly.
Mm-hmm.
So it's just a matter of us trying to figure out what we can do. For us, the donation thing has been the biggest thing that people have ever requested.
Okay.
And so kind of trying to work around some of the university policies in order to make that happen. But it was a learning experience. But
Awesome. I'm just thinking of asking our finance guy to do that, and he doesn't look happy in my imagination. So.
Yeah, no, I can tell you, she was very accommodating and she worked so hard to get it done. But she was like, don't do this to me again.
No, fair enough. But thanks so much for joining us on the podcast today.
All right. Well, thank you for having me.
Oh, our pleasure.
Thanks so much for joining us for this episode of Pep Talks, the Patient Engagement Podcast, brought to you by the Alberta Strategy for Patient-Oriented Research Patient Engagement Team. Special thanks to Paul Ferry, Sadia Ahmed, and Sandra Zielinski, and our summer students Sarah, Sydney, and Stella for their co-production. Make sure to subscribe to this podcast wherever you found it, and we hope you'll join us again for more interesting discussions about patient engagement in health research and healthcare.